Hi everybody, and welcome back to the Kaldas Center Facebook Live question and answer show. And on this cool night, it's a brisk January evening, and I've just come back from all kinds of happiness medicine in the sunshine, and so I'll bring my warm glow to you all tonight, and hopefully answer some questions about anything you want to know about what we do here at the Kaldas Center, and about endometriosis and whatever else, because we do that and a whole lot more in trying to improve people's lives, particularly you people. And so we're here to put you on the right track to a better, healthier life. And I thank everyone who has submitted their questions on Facebook already. If you have not sent in your question yet, feel free to post it on Facebook Live, and we will do our best to answer it tonight. If you would like to submit an anonymous question, which we most certainly welcome, we don't want anyone to feel uncomfortable, then please contact us using the Facebook Messenger and indicate that you'd like to share your question but remain anonymous. Hey, so before we begin, a reminder that the question and answer session is meant to be informational only. If you have serious health concerns, please contact your physician or make an appointment. If you would like to contact the Kaldas Center, visit kaldascenter.com or call us at 920-886-2299 during our normal business hours, which are posted online, and we would just love to talk to you and make you feel better. Okay, so let's get started. And so we have our first question from Jamie. Why does polycystic ovary syndrome cause hair growth? What can I do to prevent or stop it? Well, that's a good question, Jamie. And so polycystic ovary syndrome, the actual syndrome is a metabolic syndrome, and it has to do with insulin resistance at the ovarian level. And there is an increase in androgen production by both the ovaries, the male hormone production by both the ovaries and the adrenal glands. And so you end up with an elevated androgen levels, the male hormones, testosterone, and the androgens that are produced by the adrenal glands, and so you DHEAS, and so you end up with more hair growth, right? And what we can do about that is we can use combination therapy if you don't want to get pregnant, and use the contraceptive pill with something called spironolactone that acts at the hair follicle level, all right? And so you can actually improve on the hair growth by using those two medications in conjunction, or just spironolactone if you are trying to get pregnant. But you need to give it about 6 months to see the effect, because the hair follicle takes that long to cycle through. And in the meantime, obviously you can use waxing, you can use laser therapy and so on to have more immediate cosmetic result. But for long term, that is the recommendation that I would have for you. Got to control those androgen levels, okay? And so thank you, Jamie, for that question. And now from Claudette, a question about fibroids. Once uterine fibroids are removed, is there a possibility that they can return in different parts of the uterus? And are there diets or hormone treatments that can help slow down the estrogen process of these fibroids returning? Well, yes, there are such treatments, Claudette. But to your first part of the question, is it a possibility that they can return? Well, the fibroids that are removed won't return. But each of the fibroids begins with a single cell. As you know, fibroids or leiomyoma are benign growths, or sometimes they're called tumors of the uterus. I don't like using that because it gives the impression that they're cancer. But in fact, only 1 in 400 have a cancer in them. Then that's called a sarcoma, which is another topic. But anyway, so the ones that have been removed can't come back. But on the other hand, you probably are genetically predisposed to having fibroids. So other individual cells in the uterus may evolve into fibroids if they abnormally proliferate but not metastasize, and then you'll get more fibroids. And so what you can do is have a healthy diet that emphasizes not too much estrogen, all right? So plant estrogens and legumes and things like that. If you are eating a lot of soy, okay, let's say you're a vegan or something, then you can end up with actually unquantified estrogen self-medication, if you would, by taking a lot of black cohosh or whatever it is that has a lot of estrogen in it, plant estrogens, and end up causing those fibroids maybe to grow a little bit faster. There are medications that obviously decrease estrogen. And one of those, for example, is letrozole. It's Femara, and we use that as, you know, as a fertility medication for ovulation induction, but in fact is FDA approved for the reduction in the recurrence of breast cancer because it reduces the circulating estrogen. It prevents the conversion of androgens, those male hormones, to estrogens in the body, and therefore decreasing estrogen, and therefore decreasing the stimulation of fibroids. That is not usually used for the prevention of fibroids, however. And there are other hormones hormonal treatments like GnRH agonists and antagonists, you know, like the Lupron, that can shrink the fibroids, but that they shouldn't be used for so long. And the Lasolexis out for treatment of endometriosis has not been given an indication to shrink fibroids, though prior to surgery, if you have huge fibroids, you can use either one of those to shrink the fibroids in anticipation of the surgery to decrease blood loss and decrease operative time, especially if you're taking the fibroids out. Because, for example, on a uterus I took out just a few weeks ago, she had a uterus that was almost up to the diaphragm, and I wanted to shrink it just a little bit, so I shrank it down to where it was just above the navel. And I did it laparoscopically, but I actually had to take out fibroids just to get to parts of the uterus. I could do a hysterectomy, in fact, for this lady, lovely lady from Chicago, without having to open her. And then, of course, I took everything out through a tiny, tiny incision, and she went home later in the day, and all she took was Tylenol without a drop of blood lost. But so fibroids can be medically and surgically treated. Medically, they are more managed than treated, per se. Okay, thank you, Claudette, for that interesting question. And now we have a question from Grace. Is endometriosis linked to cancer? And I am at risk. I am at risk for any other serious diseases because I have endo. Oh, fabulous question, Grace. So fundamentally, endometriosis is a systemic autoimmune disorder. Okay. Therefore, for example, someone I saw for the first time today, sadly she'd had a couple of surgeries with ablative therapy and had no improvement, and of course we're going to do excisional therapy for her, and she was ready to have a hysterectomy, and I said, you don't need a hysterectomy. She was beside herself. She wants to have children in the future, but thought that she couldn't because of what had been done and it hadn't helped, but it's just because she hadn't been treated yet. And so, but anyway, and so endometriosis fundamentally is a systemic autoimmune disease, as I said. Therefore, other things that are autoimmune diseases will occur more frequently. Therefore, you have 7 times the likelihood of having a thyroid issue, like Hashimoto's thyroiditis, like that patient I was just mentioned, or rheumatoid arthritis, 5 times the likelihood, or, for example, multiple sclerosis, twice the likelihood in your lifetime. Still low risk, not to be too concerned about that. Now, the other thing on the cancer front, about anywhere between 1% and 4% of endometriomas, depending on the study done, endometriosis, growths in the ovaries, will end up actually having a cancer in them. And usually it's something called clear cell carcinoma of the ovary. However, there's also hypotheses that because the lining of the pelvis is the same embryologic origin as the ovaries, that you actually do have a higher chance of pelvic cancer when you have endometriosis, okay? That said, if my friend Mary Lou Ballweg, who heads up the Endometriosis Association of America, and her colleagues do strongly feel there's an association there, and depending on the study done, however, there may be inconsistency in what the likelihood is for someone with endometriosis to develop some kind of pelvic cancer, gynecologic cancer later in the future. Okay, thank you for that question, Grace. And now we have a question coming in from Rachel. What are the symptoms of a thyroid disorder, and how can I tell them apart from other illnesses? Oh boy, that's a good question, Rachel. So when you've got, thyroid disease, your thyroid can be high or it can be low. So if it's high, you're going to have a hard time sleeping, and you're going to be wired, and you're going to be losing weight, and you can't gain weight, and you're just your heart goes pitter patter, and you're having palpitations. You may even have chest pain. Or it can be really low, and you are just dragging around, and it's like someone knocked you over the head with a brick all the time, and you just don't have the energy for anything. Your skin gets dry, your hair may be falling out, you know, your teeth aren't doing well, you maybe even have disorders of the gum. And it's quite astonishing what thyroid disorder can do. Whether it's too high or too low, if either one of those is going on, your periods may be all thrown off, and you may not be getting periods, or they may be completely unpredictable after they were predictable. And so it's really hard to tell it apart from other illnesses. So the easiest way to do it, since the symptoms can be shared with other disorders, is to just get your blood drawn. And it's so easy to tell. Do I have high thyroid, low thyroid? Do I have thyroid antibodies? All it takes is a blood draw. Very easily done. And if you're not, when you're talking to your doc, if they're not comfortable with it, then find someone comfortable with it who's going to cut to the chase, and don't take a year to figure it out, because you'll be miserable figuring it out. Okay? And if one of your relatives, like your mom or your sister, has thyroid disease, you're going to have a way higher chance of it, or if you have endometriosis. So get it checked out. Don't live in misery. Okay? Hey, a reminder, if you'd like to set up a time to speak with us at the Kaldas Center, you can call 920-886-2299 or visit kaldascenter.com. And we have an anonymous question. What are the main causes of incontinence in younger women? I am only 33. Well, there are a few different kinds of incontinence, okay? And the number one cause of incontinence in younger women is the same as for older women, which is natural childbirth, all right? And so if you've had a couple of children, even one, and you have not been blessed with sturdy connective tissue because of your genetics, then you can be leaking when you cough and sneeze, and when you get on a trampoline, and when you go jogging. And so that is a big challenge. And I find this is just something that people don't talk about. They're embarrassed. They'll wear a pad to the gym, to their aerobics class, for years before saying anything even to their girlfriend. And I think that this should come out of the closet for people. And the sad thing is, then they mention it to their doctor, then their doctor will usually say, oh, gosh, it was just part of, being a woman and having babies. But no, and I've heard female urologists even talk like that. So don't accept no for an answer. Believe you me, don't accept no for an answer. Every doctor in this group has been told that, no, you can't do that, this, that, or the other, for whatever reason. And I have great empathy. We have great empathy with our patients who then are told so frequently, well, we can't do anything about that, or can't do anything about this. No, it can be figured out. It's not rocket science. You just have to find the right person. So other causes of incontinence, though, can be diabetes. Okay, if there's nerve damage, there can be an overactive bladder. The same reasons as someone who's older, but usually it is childbirth and the relaxation, the stretching that happens, or even nerve damage. Let's say you took 4 hours to push a baby out. There can be nerve damage right there where the urethra meets the bladder, and resulting in an incompetent sphincter of the urethra, and that will result in incontinence of urine. Thank you for that question. And I can understand why you are anonymous. Hey, from Renee, what are some of the signs and symptoms of thoracic endometriosis? What are the first steps to getting a diagnosis? That's an excellent question. I had a case a few weeks ago where she presented with right upper quadrant pain. And she had, ultimately we found out, endometriosis, but no one could figure this out. Of course, a CT scan was done, nothing was found, so on and so on. But it ended up she had a big old, deep nodule of endometriosis right into her right diaphragm. And so, with excellent support from general surgery there at Theta Care, I went and had proceeded to excise the endometriosis from the diaphragm, okay? Because you get a lot of referred pain and sharp shooting pains into the chest, can radiate to the back, can radiate to the shoulder, because you're stimulating the nerves and you get referred pain to the shoulders and this radiating pain in the chest. It will usually happen on the right side, but it can happen on both sides. Usually people will not want to go cutting into the lung in order to look for endometriosis unless an MRI shows it like something, because it is no, it would be a very difficult diagnosis to make just by exploratory thoracotomy. That just isn't done. However, if you do have laparoscopy, you see it on the diaphragm growing into the chest, then you can excise it from below. Even if you have to do a full thickness excision of the diaphragm laparoscopically, then you can sew up that diaphragm laparoscopically, and you deal with the pneumothorax that would occur. So that is all doable, and those are the signs. However, even if you don't have thoracic endometriosis, and you have endometriosis, there's some excellent work that's been done recently that people with endometriosis can still get chest pain because they have higher levels of neurotransmitters that transmit pain, okay? And they're shared, and the brain where pain perception occurs in the prefrontal cortex is different for people who experience pain with endometriosis than those who don't. And so a lot of excellent work that is finally being done on this topic. So please don't think that you necessarily have thoracic endometriosis. It may be real pain, but not necessarily with actual lesions in the chest. Thank you for that question. And from Brittany, tracking fertility ovulation is such an exhausting chore. Oh my gosh, it is. Any recommendations on apps, test strips, and what should be tracked, or what should you look for? Excellent question, Brittany. I tell my patients, no, don't do it. Don't track, okay? It'll drive you crazy. And so the reason being is because sometimes those kits are hard to read and are misleading, okay? And so I recommend that you simply figure out how long your cycle is. If you have polycystic ovaries or an irregular cycle, then you are going to have a hard time with that. And you need to be looked at by someone competent in this field, okay? And so let's say, however, you have a 29-day cycle and it's like right on clock, right on time. Don't track it, please. Put away the ovulation detection kits, save your money, and for you, 99% chance you're ovulating on day 15, because 99% of the time, women ovulate 14 days before their next period. Doesn't matter when they had their period, matters when they're going to have their period. Therefore, sperm will live for 4 days, naturally, if it's processed about a day. But naturally, sperm will live for 4 days. Egg will live for 12 to 24 hours. So, the highest concentration of sperm, technically, is if you have intercourse every 38 hours. Don't do that. Every other day, we say, okay? So beginning 4 days before ovulation for you, start having intercourse every other day. So if you're ovulating on day 15 for a 29-day cycle, you have intercourse on cycle day 11, 13, 15. Maximizing concentration of sperm at the end of the fallopian tube when egg is released and ovulation happens, and maximizing chances of pregnancy. Way more effective than driving yourself crazy for that totally unspontaneous situation. Oh my gosh, it's positive, we've got to do it. No, that'll drive you crazy, it's not romantic, it's none of that. So that's what I recommend. If you have a variable cycle, on the other hand, one of three things is happening 99% of the time. Either your prolactin is off, you've got polycystic ovary syndrome or polycystic ovaries, or you've got a thyroid issue. Almost always, all right? One of those three things is happening, and it's easy enough to figure out and remove unknown variables so you can time it right and get it right. Okay, so good luck with that. Thanks for the question. Hey, a reminder that if you want to set up a time to speak with us at the Kaldas Center, then call 920-886-2299 or go to kaldascenter.com. From Drew, I have had a good experience using progesterone in pregnancy, but it seems to be a highly debated topic. What's your stance on progesterone support in pregnancies in order to prevent miscarriage or preterm birth? Well, I've used it for both, and the literature is quite clear that the product McKenna, if you've had a preterm birth previously, does statistically significantly reduce the risk of preterm birth. The problem is when the medication came out, it was compounded and by pharmacies, and it was like $50. Then suddenly patents happen, and suddenly it's like they're charging $1,700 a week for this medication. And it has become unaffordable, and a lot of insurance companies, understandably, won't pay for it. And so the progesterone suppositories are then used. However, their indication is if you have a short cervix, discovered during the pregnancy. They have not been proven to improve chances of, or reduce chances of preterm delivery if you've had a prior preterm delivery, but only improve your, prolong the pregnancy if you are discovered to have a short cervix during the present pregnancy, okay? Therefore, I think there's a role for progesterone and to reduce the risk of premature delivery, knowing which medication for which specific situation. As far as reducing the risk of miscarriage, if you are the rare person with a luteal phase insufficiency, okay, which we don't even test for anymore, all right? Most of the people who do reproductive endocrinology don't do that because it's painful to do an endometrial biopsy and you're supposed to repeat it to confirm it the next month and so on and so on, and it's expensive. And it's just so easy to give progesterone until, say, 10 weeks gestation, anywhere between 8 and 12 weeks gestation, and 8 and 14 weeks gestation I've seen. And it's just so easy once you get pregnant to eliminate that possibility. However, the literature does not say that is evidence-based. And there is where the thing is. The evidence would suggest that progesterone doesn't reduce the risk of miscarriage. However, why not theoretically reduce that risk? And almost anyone who does this goes ahead and gives you progesterone just to eliminate that possibility, that small chance that you're someone with luteal phase insufficiency that would contribute to a miscarriage, a hormonally based miscarriage, which is a rare. Most miscarriages are not because of hormones. The overwhelming number of miscarriages are because of genetic abnormalities. Common things are common, and that is about 80-85% of all miscarriages are just because the conceptus is genetically not normal. But anyway, Drew, that was an excellent question. And so if someone does have a luteal phase deficiency, then I would absolutely positively, right when you find out you're pregnant, go ahead and start progesterone. Some people would even say if you're doing reproductive cycles, to start it like 4 days after you have the insemination or timed intercourse, so you have it on board. But remember, it will cause you to miss your period and confuse your cycle, and so you'll have to do a pregnancy test before you stop the progesterone. And then if you're not pregnant, then you go ahead and stop the progesterone, you have a period, and so it does throw things off a little bit that way. But for someone with luteal phase deficiency, most certainly should be doing that. Okay. So, from Sandra, when was endo treatment introduced? Years ago I was told I had it, but only told having a baby would help. Oh my God. Sandra, all right. So, you're like our average patient. And so what you'll find is the pioneering treatments for endometriosis did not happen until the advent of laparoscopy, okay? And that was in the late 80s. I had the privilege of having Dr. Cameron Najat, a pioneer in laparoscopic surgery, be my mentor when I was at Stanford. And as you know, perhaps Dr. Wong trained with Dr. Najat's brother, Dr. Far Najat. And so, and Dr. Meni is an outstanding laparoscopic surgeon in his own right after being at the Kaldas Center for almost 5 years. And so, laparoscopic surgery led to the proper treatment of endometriosis. That was around late 1980s. That was the first time that Dr. Najat put a camera on the laparoscope. And it's quite funny to go online and see these pictures of him holding this huge 20-pound Panasonic camera or whatever it is on a scope, because before the surgeon would have to bend over and look through a small hole, and obviously you're not going to get very advanced surgery done that way. He was also the same one along with a guy named Yona Tadir who connected a laser to it, okay? A laser. And with that, off and running. And also great pioneers in endometriosis surgery like David Redwine out of Bend, Oregon back in the late 80s, 1980s and early 90s, who actually worked with Nancy of Nancy's Nook. Who knows just a little bit about endometriosis, as you may know. Anyway, so thank you, Sandra. That is when treatment for endometriosis really took off, and we know that excisional therapy is the best way to go now. Really the only thing that treats it. When I say excisional therapy, I don't mean taking organs out. You can treat endometriosis and get excellent results without taking organs out. And I do it with laser laparoscopy. I find that to be very highly efficient after so many thousands of surgeries, and it can be done quickly and safely in the right hands. From Natalie, can you develop endometriosis at any point during your life? Really, Natalie, it is reproductive years. However, quite young women have had endometriosis. Few months ago, I've operated on several teenagers over the years. A few months ago, I had an unfortunate case where a young lady had horrible menstrual cramps or horrible belly pain for like 5 years, from the age of 11 to 16, before she was discovered to have an imperforate hymen. And so the blood was not getting out, and so all of that menstrual blood for 5 years was going backwards. Well, she got a nasty case of adenomyosis uteri, endometriosis of the wall of the uterus, as well as endometriosis all over her pelvis because of that unfortunate delay in diagnosis. And so, and that's going to be something that needs to be managed throughout her life. But you can have a genetic predisposition and get it as a teenager. You can get it all the way through your reproductive years, and then it can be stimulated by hormone replacement therapy in your menopausal years. This is one of the reasons that it is very important, even if people think that if they have a hysterectomy, it will cure endometriosis. It doesn't. You have to get rid of the lesions. If you have a hysterectomy to get rid of the pain of endometriosis, and you leave all the endometriosis behind, if you leave the ovaries, it's still going to be there and you're still going to be in pain. Okay? If you, let's say, take the ovaries and the uterus out, then you calm the endometriosis down, but there can still be scarring with all kinds of nerve involvement that still causes pain. Or if you end up needing hormone replacement therapy for other reasons, that will stimulate implants, and here you are, a menopausal woman without ovaries, with her endometriosis that was never removed, being stimulated. So yes, you can give HRT to a menopausal woman and stimulate the endometriosis, but it is very unlikely that endometriosis occurs for the first time de novo in a menopausal woman. Okay? Thank you, Natalie. And from Amy, could you please explain insulin resistance? Oh, what causes it and what can be done to help? Amy, well, obviously we know a little bit about insulin resistance because of the polycystic ovary patients. Okay, so insulin affects almost every organ in the body. It affects the skin, it affects the brain, it's the receptors everywhere. And you need insulin for normal ovulatory functioning. It is the certain cell type in the ovaries that respond to insulin, as well as other biochemically mediated factors, okay, that cause ovulation to occur, the sequence that leads up to ovulation. Insulin is one of those things that is necessary. And so you give an insulin sensitizer. And the usual one we use is called metformin. It's been around forever, and it's very safe. And in fact, we will frequently give it until week 10 during pregnancy, because there's some earlier evidence that suggested that it does reduce the risk of miscarriage associated with polycystic ovary syndrome. And so that is the treatment for insulin resistance, which is simply an insulin sensitizer, and it doesn't bottom your sugars out because it's not doing anything to the pancreas. It's simply sensitizing the end organs, the cells, to insulin so they respond normally to insulin. And that is insulin resistant. And it is fundamentally a genetic predisposition. The genes are not letting those insulin receptors respond. And if that helps answer your question. From Jennifer, at what age do PCOS symptoms start to show? I am concerned about my teenage daughter. No, Jennifer, it's in teenage years, because you have that genetic predisposition to polycystic ovary syndrome, even though you may not have it yourself, Jennifer. And then what happens is those ovaries are not working as usual, and you end up with that overproduction of androgen, and you can have the abnormal weight gain and difficulty losing weight and the hair growth and the stria on the abdomen and all of that, okay? And higher incidence of diabetes and all that, okay? And so it is during the teenage years. So for example, some cases of what's called primary amenorrhea, meaning the child is not having periods until, they're 16, 17, they're still not getting period. It is because of polycystic ovary syndrome. Of course, that would need to be something to be evaluated to rule out other genetic, possibilities or something else, uterine malformations that's contributing, or imperforate hymen or something like that that's contributing to an absence of menses. But it is teenage years that you'll frequently see polycystic ovary syndrome developing. There's frequently a delayed diagnosis at that time, and you want to check that out. You can look at the back of your daughter's neck if you're thinking she's having some signs of it, and if she has deeper, darker wrinkles on the back of her neck, that's something called acanthosis nigricans, and if she has that, it is almost certain that she has polycystic ovary syndrome. And give us a call and we'll help you figure that one out so she doesn't have to deal with all that challenge by herself of the weight gain and all that, because that affects girls' psyches, and we just don't want that to happen. We can't let that happen, okay? All right, my gosh, I cannot believe the time is up already tonight. Thanks everyone who joined the conversation. If we did not get to your question, we will follow up with it in the next few days. A quick reminder that if you'd like to speak with us further, you can contact KaldasCenter.com or call us at 920-886-2299. Thanks again for joining us, and remember, don't take no for an answer. I can't do, nothing to do about it. We just don't even, we have very little tolerance for that at the Kaldas Center. We want you to get answers. This is not rocket science, and we want you to feel better, and we can make that happen. You have a good night.